catheter valve. As you will probably know, the Achilles heel of the first generation ACURATE Neo was the high rate of post-procedural aortic regurgitation, mainly due to paravalvular leaks. The Scope 1 trial compared the performance of ACURATE Neo versus balloon expandable SAPIEN 3 valve. The incidence of moderate or severe paravalvular regurgitation was inferior in the SAPIEN 3 group, with almost 10% of patients implanted with ACURATE valve presenting a moderate or severe aortic regurgitation at discharge. Those data were confirmed also in the Scope 2 trial, which compared the outcomes after implantation of self-expanding ACURATE Neo versus Evolute R. Again, 10% of patients treated with ACURATE valve showed moderate or severe paravalvular regurgitation at 30 days. So the neo2 valve maintained the favorable characteristics of the first generation, including low transposthetic gradient due to supraannular function, low rates of conduction disturbances due to lower radial force, and easy coronary reassess. Plus, it incorporated an active sealing skirt to minimize, to mitigate the occurrence of paravalvular regurgitation. So let's see the design of the study, the analysis. It included data from the NEOPRO and the NEOPRO2 registries. These are retrospective observational real-world registries, including patients treated for severe aortic stenosis with a transfemoral TAVI, so pure aortic regurgitation were excluded. Implanted valves were ACURATE Neo and Evolute Pro for the NEOPRO, and ACURATE Neo2 and Evolute Pro Plus for the NEOPRO2. Among the whole population, 2,026 patients were included for the selected analysis, and of them, 1,263 were treated with the ACURATE Neo first generation valve, and 763 were treated with the second generation ACURATE Neo2. Primary endpoint, as you can see, was the occurrence of moderate or severe paravalvular aortic regurgitation at discharge, assessed with echocardiography. And secondary endpoints were 30 days VARC-free clinical outcomes, 30 days occurrence of permanent pacemaker implantation, and 1 year overall survival. These are the baseline characteristics of the included population. Mean age was 82, and 66% of the population were women. As you can see, the Euroscore 2 and the STS score were slightly higher for the first generation device group. And the results in terms of safety were similar for the two groups, with a VARC-3 technical success of 91% in the first generation group and 93% for the Neo2 group. Also, the need for permanent pacemaker implantation was low and similar in the two groups, 9% versus 8%. These are the 30 days outcomes. As you can see, VARC-3 intended performance of the valve was significantly higher for the new generation valve, for the Neo2 valve. VARC-3 is intended performance of the valve is a composite outcome, achieved with a mean transprosthetic gradient less than 20, peak velocity less than 3, and Doppler velocity index more than 0.25 and less than moderate aortic regurgitation. Moreover, fewer vascular complications were seen in the Neo2 valve. As you can see, the improvement of the intended performance of the valve was mainly driven by the reduction in the rate of moderate or severe paravalvular regurgitation, 5% in the first generation versus 2% with the ACURATE Neo2, and 59% of patients treated with the Neo2 valve showed known or trace paravalvular leak, while this was seen in only 38% of patients treated with the first generation device. The author also showed an interesting sub-analysis stratifying the overall population according to the grading of baseline aortic calcification. And the significant reduction of moderate severe aortic regurgitation was observed only in the subgroup with heavy aortic calcification. So 9% with the neo valve versus 2% with the neo2. Finally, as shown in the overall survival curves, the survival at 1 year was similar for the two groups, 90% versus 87%. These are the conclusions reached by the authors. So first of all, the latest generation ACURATE neo2 was associated with a significant reduction in post-procedural moderate or severe paravalvular aortic regurgitation. Second, a similar need for permanent pacemaker implantation was observed between the two valves generation. And the superior performance in terms of aortic regurgitation of ACURATE neo2 was evident, particularly in severe aortic valve anatomies. Finally, TAVI with ACURATE neo2 was associated with a reduced rate of vascular complication, mainly due to the more expertise of the operator of the second generation. So I conclude with two questions for Professor Giannini. The first one is, do you think that these results are mainly due to technology advances, for example, the active sealing skirt, or more to the improvement in the learning curve of the operators with the ACURATE system? And the second one, do you think that the result may be influenced by an extreme patient selection? I mean, after the published results of the SCOPE 1 and the SCOPE 2 trials, operators might have chosen to implant ACURATE valve only in selected patients with suitable anatomies. So could this constitute a bias of selection?
Okay. Nice. Francesco, before we get into some of these questions, I would say that a lot of young interventional fellows connected today, and perhaps most people are familiar with at least the Edwards and the Evolute platform in terms of what's available in Cath Lab. So perhaps to begin with, if you could tell us a little bit about this valve and your experience with this valve, and then we can move into the questions.
Okay, so thanks Mauro, and thanks Arif. So the ACURATE valve is a supraannular valve, is a self-expandable device, is a not retrievable device. So it has some, I would say, positive, some strengthness and some limitation. So first of all, the main characteristic of the valve is that it's a supraannular, so we can say that it's quite well performant in case of small annuli, or in case of, for example, valve in valve, can be really useful. But at the same time is released quickly in a two-step procedural steps, so has the advantage not to give the hypotension that we usually, the transient hypotension that we usually see when we use other self-expandable devices. So I would say that is a quite good valve that I prefer to use, especially in a specific setting. It has the stabilizing arches that are released during the first step and allow the valve to be centralized and well aligned. And this is the reason why is really well performant in case of horizontal aorta, when we have always some, we struggle in try to be well aligned when we utilize other self-expandable devices. So in case of horizontal aorta, for sure is a good option. I prefer to utilize also in case of low flow, low gradient patients, severe aortic stenosis patients, just because we don't have the transient hypotension that we see with other self-expandable devices. So in case we don't want utilize a balloon expandable, and or is not available in the hospital is a good device to be utilized, just because we don't have the hypotension and we risk to have troubles with the hemodynamics of the patients. And is also a good valve that is not allowed to be utilized because it does not have the CE mark approval for the valve-in-valve setting, but just because as a very low profile, I think provides the advantage in the setting of valve-in-valve not to leave too much metals around the coronary ostia, so potentially to facilitate the re-engagements. After the first trials, the scope 1 and the scope 2, operators, it's true, believe that this valve is not well performant in severely calcific anatomies, and this is probably why this is mainly because of the low radial force, but after the improvement with the neo skirt, probably this issue was overcome. So I would start with the first question from Mauro. So let's start with the primary endpoint. So we had a significant reduction of moderate to severe paravalvular leak at 1 month, as detected by Doppler echocardiography. This finding is not surprising, is, I would say, expected, considering that the new platform was improved with a 60% larger cell skin just to address this issue. So it's not surprising. It's true to have an improvement for 5 to, we did not only see an improvement in moderate to severe paravalvular leak from 5% to 2%, but we had also a significant reduction of mild paravalvular leak. So with a new platform, at 1 month follow-up, we have up to 60% with the non or trace paravalvular leak, as compared to the previous platform that was 35–38%. And this is quite relevant because we know that also mild paravalvular leak may have an impact on left ventricular remodeling and long-term mortality. So we don't have only to look at the moderate to severe paravalvular leak, but also to the residual mild paravalvular leak. This is, I would say, shows a dramatic reduction as compared to the scope 2 trial, where the rate of moderate to severe paravalvular leak was around 9 to 10%, but it's something expected. It's something expected because the valve was improved a lot thanks to the expansion of the skirt. Other consideration, going a bit more in details through the data, is that there is no difference in terms of need of permanent pacemaker, and this is also something expected because there is no reason to have a reduction of need of permanent pacemaker with a new device. What is quite relevant is a reduction in both minor and major vascular and bleeding complication. Probably vascular complication, it's true, was partially related to the increased operator experience with this system, but probably is also thanks to the 14 French expandable ISLI device that was introduced in the last 4 to 5 years. So it was utilized in all the patients treated with the neo2 and only partial in the patients treated with the first generation. And this is really helpful. It's a very good introducer that allowed the operator to manage very challenging anatomies, because you advance the introducer in a very low profile, and then you expand the introducer by advancing the valve inside it. It helps a lot when the femoral artery is quite small or very calcific, and there is an important tortuosity. And there is also a significant reduction of bleeding, and this is probably partially related to the different treatment period of the two populations. So we know that ACURATE Neo was utilized from 2012 to 2018. and patients treated with the ACURATE neo2 were treated in the last 2 to 3 years, so from September 2020 to December 2021. So probably we are looking at different population. ACURATE neo2 patients have a higher prevalence of cage, lower glomerular filtration rate, and higher prevalence of NEA class 3-4, even if mild, a lower left ventricular ejection fraction that was significant, but especially a significantly higher mean Euroscore 2 and STS score. So probably the reduction in bleeding was related to the fact that we are looking at the different population. Another important aspect is that the need of post-dilatation with a new platform was required in a reduced percentage of patients, so 42% versus 31%. And this can have an impact. Sometimes just performing the post-dilatation, we create some conduction disorders. So if we have a reduction in need of post-dilatation, it's something relevant. And we know that when we use self-expandable valves, the main cause of annular rupture is the post-dilatation. In this study, there was no difference, but we saw 4 cases of annular rupture in the ACURATE neo group, only 1 case in the ACURATE neo2. We don't know if they were caused by the post-dilatation because it's not reported in the manuscript, but this may have an impact. So the fact that we reduce the rate of post-dilatation, we reduce the rate of complication in general.
Great, thank you, Francesco. So Julia, maybe we can start taking some questions. So Julia, do you want to direct your question?
Yeah, thank you, Arif. To curiosity, what about the technique of dilatation? Do you talk about post-dilatation, but do you usually perform a pre-dilatation? And what about alignment?
Very nice question. So I was used to perform routinely pre-dilatation with this valve because of the low radial force. And this is something that I would do also after the publication of the study for sure. When I avoid to use the pre-dilatation is just when the degree of calcification is very low. Sometimes I utilize also this device in pure aortic regurgitation. It's also a good device for pure aortic regurgitation when the perimeter of the annulus is below 67, 80 millimeters. And of course, in this case, we don't need any pre-dilatation, but I would say that in 90% of the cases, I use pre-dilatation. I use post-dilatation only when I do not have a satisfying result, mainly because there is some paravalvular leak, sometimes for the residual gradient. Looking at the data of this study, there is, this is something I think to discuss also, a significant increase of the residual gradient with the second generation device. Probably this is just because the use of the need of post-dilatation for the residual paravalvular leak was lower. Alignment, it's crucial. Now, finally, we really are understanding that is important to facilitate reaccess because we are moving to younger patient and lower patient. This device has, I would say, unique features that help in the alignment because we can see while we are implanting the device where the posts are located, and what we have to do, we have to avoid just to land with the post of the device in front to the coronary. So what I utilize is the technique that at the beginning was a device technique, device-specific technique. So simply by advancing the valve with the flash port located below, looking down at 6 o'clock, but now we know that it works and guarantee a good alignment, not in the all the cases, but in the majority of cases. We need some manipulation. What I utilize is the technique that was suggested by the colleagues from Karolinska. So utilize a patient-specific alignment technique working in two different views, the left-right overlap view and the three-cusp view. And I don't want to go too much in detail, but we know that we can guarantee by using this technique a good alignment in around 95–90% of the cases. And these devices, compared to others, really facilitate a good alignment position just because of the radiopacity of different elements of the device that help a lot to the operators.
Thank you very much.
Thanks. Oh, so do you have one more question, Julia?
Yes, it's only a thing, but talking about radial force, do you think, and patient selection, do you think that large annuli and heavy calcification will remain a sort of limitation for this valve?
I know that the company is working to improve also this aspect, so to improve the radial force. So in the next generation, probably we'll have some benefit in terms, and we will have also a size to treat larger annuli. So probably this issue will be overcome in the next years.
Thank you very much.
Great. So Evelina?
Hi everyone. So I wanted to comment about you just mentioned it, there was a difference in terms of paravalvular regurgitation with ACURATE in the population of the SCOPE 2 trial, and then the NEOPRO and the NEOPRO2. So I'm guessing, but this is my opinion, I would like to hear your comment. Maybe there was a first time when operators that had experience with the Evolut platform started to do the randomization. So at the beginning of the experience with the ACURATE valve, maybe results were not so good, but then came data from the NEOPRO. So I think there was some more operator experience, and now we have a lot of experience with the new generation valve. So in your mind, how much the operator's learning curve has an impact in terms of procedural results and optimizing procedural results? So low gradient, low rate of paravalvular regurgitation, achieving commissural alignment, and also if you have any advice for colleagues that have grown with a difference of expandable valve, like the Evolut, for example. There's a difference when you move to the ACURATE platform. So do you have suggestions for those colleagues that move with this new valve?
Yeah, thanks, Evelina. So I would say that learning curve in our job is crucial for every kind of procedure that we perform. Now with the ACURATE, we know how we have to implant it. We know, for example, the implantation depth. It's a crucial point because we have to utilize the level where the valve has the higher radial force. So we have to go at the height of 7 millimeters, and then we know that we can guarantee we can really use in the better way the radial force. So also in this case, looking at the whole data we have with the ACURATE, probably learning curve had an impact. If we see the SCOPE 2, really there was a dramatic reduction in moderate to severe paravalvular leak from 10% to 2%. We know that in the SCOPE 2, also severe leaflets calcification were allowed to be included in the study. We also know that in the study just published in Eurointervention, there was no core lab. So partially, we have also to accept that sometimes without core lab, we cannot be assertive and say that really that was the degree of regurgitation. You know, when you don't have a core lab and you have a mild paravalvular leak, sometimes the mild means moderate, sometimes mild means trace, so it's difficult to understand. But probably the reason why we have this discrepancy in data is that the the scope 2 was a trial, and we noted usually in the trial patients are selected, are partially selected. The strengthness of the registry is that often we enroll patients, unselected patients, so consecutive patients. So probably just the data that we see from the Eurointervention just published study are the real world data. And there was a real good improvement with the second generation device. So I would say that after this data, probably I would suggest to utilize also this valve in more severe calcification if when we have LVOT calcification and we want to utilize a supraannular valve, for example, in the small annuli setting, or in a low flow, low gradient patient in which we prefer to utilize a self-expandable valve is a really good device because we use the supraannularity, but at the same time we don't have the transient hypotension that we can have with other self-expandable devices. So probably these are the settings where I would prefer to use prefer these devices. Now I would say also regardless of the degree of calcification. And the data that we saw from the Andrea Scotti paper are also, let's say, is also the feeling that we have when we use this valve. We were used to manage to phase with the residual moderate to severe paravalvular leak. Now is very rare with the new platform.
Okay, great. So we're almost at time. Maybe I have a last question for Francesco and then also a last question for Mauro at the end of that. So Francesco, for you, it seems like TAVI has come a long way. We've really improved acute procedural outcomes, made a big difference to, you know, stroke, paravalvular leak, pacemakers. What's next? What do we have to do next? What do you as a TAVI operator want to see from, let's say, the next 10 years in TAVI? What do we have to try to think of as physicians? You're on mute.
Sorry. So I think the main two issues that are still open are probably one related to the durability. So we really need now to have data, also to convince cardiac surgeons that TAVR does not have this limitation. This is something that we feel, but we need the data to prove it. And the second main issue is related to the reaccess to coronary artery. So this is very important looking at the patient that we are treating now as compared to 10 years ago, and we are going to treat in the next 10 years, so younger, lower risk, with a prevalence of coexisting coronary artery disease that is quite high. And we have, when we perform now a TAVR, think about the future, the next 10 years. So we have to try to implant in the best way the better valve for the specific anatomy to guarantee the reaccess to coronary artery, and at the same time we have also to think about redo TAVI that may may be needed in the next 10 years. So to address these two issues, now we need to work on data. We need to build experience, and probably answers will come in the futures. Probably also new devices. Let's see, what we learn is that technological improvement is completely unpredictable. So what we can do now is just to have an optimal final result that not only guarantee no paravalvular leak, a good residual gradient, but also that guarantee reaccess to coronary artery and eventually the position of a second valve. And then let's see what will come in the future in terms of technological improvement.
Great. Okay. Thank you for that little like snapshot into the future. And then Mauro, my last question is for you. So first of all, congratulations for this work and being involved in this project. As you know, this journal club really is an avenue initiative for young or let's say early career interventional cardiologists. Tell us a little bit about your experience being involved, because you were involved in a project which was quite a big multi-center, multi-operator project. And of course, there's all these big names on such a paper, but then you're just a, an early career fellow in the middle of all of this. But what's your experience of being involved in such a big project? How did you find, what did you learn? And can you maybe share some useful insights for the other young people connected?
I think it's always good for young interventional cardiologists, as I am in the first year, being involved in such registries and multi-center projects. Of course, we young have always to thank our mentors, because I think the main important thing is to have a mentor which is keen on involving you in those projects. Plus, you have to be very, very active in studying and going on with research and trying to do both the cath lab activity, which is of main importance in our career, but also research. So these two aspects, having good mentors. In my case, in Brescia, I have to thank Mariana Adamo, which is very active in research, and this is
great. So very useful. So find a good mentor and then basically just work hard now. Good. Okay. So I think we've come to time. So maybe let's conclude the session there. Just thank you very much, Mauro, for joining us and presenting, and also for your insights at the end. And Francesco, it was a great pleasure to have you, for your insights and experience with this valve. And thank you for your comments.
Thank you, and good morning, everybody.
Great. So we'll be back, everyone, next week, back with Journal Club. And yeah, have a nice Friday, good weekend, and see you next week.
Have a nice day.
Ciao.
Thank you. Bye.
Bye. Bye.
Ciao.